Welcome to the deep dive. Today we're doing a really focused exploration of mPharma, a groundbreaking African health tech company.
Hmm.
We're going to chart how they managed to make essential medicines both affordable and actually accessible, starting in places like Ghana.
Right.
Our goal here is simple: to distill their idea, their value proposition, their, key milestones, and the real impact they've had on patients and local pharmacies.
And to really get what mPharma's proposing,
Hmm.
you have to start with the reality they were facing.
Hmm.
I mean, it was dire.
You're talking about that concept of unjust healthcare access.
Exactly. Before mPharma, it was just normal for patients across Africa to pay up to 3 times as much for medicine,
3 times as much.
for the exact same pill you'd buy in Europe or the U.S.
That statistic is just staggering, especially on a continent where disposable income is so low.
It is, and it wasn't just about the money. It forced these unbearable human trade-offs.
Like what?
Well, our sources talk about mothers having to choose. Do I buy my life-saving hypertension medication this month, or do I pay for my child's school fees?
You can't even imagine having to make that choice.
You can't. And to fix a problem that deep, you can't just lower the price a little. You have to fix the entire system that creates that injustice.
Okay, so let's go upstream then. The high out-of-pocket cost was the symptom. I think I saw that only about 40% of Ghanaians even have active health insurance.
Right.
But what were the systemic failures in the supply chain that were causing all this?
The problem was pure fragmentation. The whole distribution system was, for lack of a better word, a mess.
And that created what? 2 main issues?
2 huge issues. First, really poor demand forecasting. This meant facilities had these widespread stockouts.
So the pharmacist just has no idea what to order or when.
Exactly. So a patient shows up needing medicine, and the shelves are just empty.
And then the geographic inequality just made that so much worse, didn't it? If you lived in a rural area, you were basically cut off.
Absolutely. In Ghana, something like 75% of all formal licensed pharmacies were in just 2 cities,
Accra and Kumasi.
Accra and Kumasi.
Yeah.
So if you lived anywhere else, you had to rely on these limited informal vendors, licensed chemical sellers.
Who can't stock the same range of drugs?
Not at all. And this created a vacuum, which, coupled with weak enforcement, just flooded communities with substandard and counterfeit drugs.
Which erodes trust in the whole system.
Completely. I mean, if the shelves are empty, the prices are all over the place, and the medicine might be fake, why would you even engage?
People just stop trying.
Precisely. The sources show the result of all this inefficiency is that many people just started self-medicating, or they avoided treatment altogether.
And this is happening right as chronic conditions, things that need continuous care, are rising.
Right. Diabetes, hypertension, these are on the rise, and they demand reliable, continuous access to medicine. That was the huge systemic problem mPharma had to solve.
Which brings us to the founder, Gregory Roxon. He started mPharma in Ghana back in 2013. He was, 22 years old?
Just 22, yeah. And his vision was deeply personal. He'd seen his own family struggle to afford his medicine.
He saw the infrastructure itself was the problem.
And what's so fascinating is how their solution evolved. The first attempt from, say, 2014 to 2016 was purely a tech play.
The Electronic Prescription Network, or EPN?
Right. The idea was to connect doctors, patients, and pharmacies digitally to map supply and demand.
And the business model was to sell that data.
Yeah, monetize the data. And on paper, it looked great. They even attracted partners like Novartis and Pfizer.
Okay, wait, so they had this brilliant digital idea to map the entire market, but it failed because the actual pharmacies on the ground weren't ready for it.
That's the necessary lesson they learned. You see, these small independent pharmacies, they weren't digitized. They couldn't, or maybe just wouldn't, report back when prescriptions were filled. So pharma was capturing almost no point-of-sale data.
So the EPN couldn't scale.
And the company made no profit in its first 2 years. They realized that just providing information wasn't enough. It didn't actually lower prices or improve availability.
So that forces the huge pivot in 2016. They had to stop being just a tech layer on top and, as they put it, move up the pharmaceutical value chain.
They had to become a drug supplier themselves to get control.
And that's where the vendor-managed inventory, or VMI, model comes from.
Yes. So pharma starts using shared data to forecast demand, and then they replenish the stock for the pharmacies. This solves that stockout problem.
But the real innovation was the financing, right? The stock was supplied on consignment.
That was the radical part. The pharmacy didn't pay pharma a thing until the drug was actually sold to a patient.
That's a massive shift. It frees up all the pharmacy's working capital, which for a small business is everything.
It's their lifeblood.
Mm.
And the approach worked immediately. They ran an early pilot at the Ghana University Teaching Hospital, and it led to a 30% reduction in drug procurement costs for the hospital. A
Uh-huh.
huge validation.
A 30% cut for the institution is huge. But did that saving get passed on to the patient right away?
And that was the next big hurdle. Unfortunately, no.
Ah.
Even with 30% lower costs, mPharma found that pharmacies were often not passing the savings on. They kept retail prices high.
Why? To cover their own costs.
Exactly. To cover rent, staff, the cost of fixing up a rundown storefront. So mPharma realized, okay, it's not enough to control the wholesale price. We have to control the retail price.
They had to control the last mile.
They had to, which led to the Quality RX program in 2018. This was their retail franchise model.
So they basically turned all these independent pharmacies into a kind of cooperative.
Yes, which they later branded the Mutti Pharmacy Network, and they backed it with serious capital.
Right, they helped fix up the dilapidated stores.
They injected capital directly. They offered renovations, new stock, and even up to $10,000 in interest-free loans for modernization.
There's that great case study of fresh spring chemists in Ghana. It was about to collapse.
Right, and then Pharma restocked and refurbished it, all at no upfront cost to the owner. And suddenly, customers came flooding back because the place looked professional and, actually had medicine on the shelves.
So what was the trade-off for the pharmacy owner?
And this is the crucial part for the patient. In return for all that support, the pharmacies had to agree to a few things.
Okay.
Use mPharma as their sole supplier, share a portion of their profits, and most importantly, they had to let mPharma set the standardized prices in the store.
And that's the final step. That's
Yeah.
what ensures the savings actually reach the patient's pocket.
That's the lock. It guarantees affordability.
So if I'm trying to boil this down for you listening, the genius here is that they found a way to subsidize the pharmacy with financial relief.
The consignment stock, the loans.
In exchange for mandatory centralized control over patient pricing. Is that the fundamental exchange?
That is precisely the core mechanism. It solved everything at once. The supply chain, the cost of goods, and the pharmacy's lack of capital.
So with that model working in Ghana and Nigeria, they went into this aggressive expansion phase.
Super aggressive. From about 2019 to 2021, they used strategic acquisitions to just jump into new markets.
And the Halton's pharmacy deal in Kenya was a huge one.
It was unprecedented. They acquired the second largest pharmacy chain in the country, giving them an instant, massive footprint in East Africa.
Then they went into Uganda.
Yep, acquiring a majority stake in Vine Pharmacy. By 2023, they were operating in at least 9 African countries.
And this whole network is only possible because of their tech platform, right? The software that runs everything.
Absolutely. The digital backbone is called Bloom software. And it's so much more than just a point-of-sale system.
What does it do?
Well, Bloom digitizes every single sale. It finally captures that data the first EPN system couldn't get. That gives them the accurate forecasting for the VMI system to work.
And it enforces the pricing.
Critically, yes. It enforces that centralized, uniform pricing across the whole network. A pharmacist physically cannot override the price.
And then for the patient, there's the Mutti program.
That's the patient loyalty platform.
Yeah.
And the discounts are transformative. We saw data on one blood pressure medication that cost 56% less for a Mutti member.
56%.
And for people who still can't pay that lump sum, they have the Heal Now, Pay Later option.
So you can pay in installments.
Yeah, you pay a bit up front and the rest over 30 days. In a market where cash flow is everything, that is a game changer for medication adherence.
And this whole model is now evolving, right? The pharmacies are becoming more like primary care hubs.
They are. They're adding things like telehealth consultations, Mutti Doctor, and diagnostic testing, like blood pressure checks, right there in the pharmacy. They're becoming real community health centers.
So let's just synthesize the outcomes. What has the impact really been?
Well, the network now includes over 1,000 partner pharmacies and hospitals. The sources confirm it's benefited more than 2 million people with lower prices.
And the availability numbers, I mean, that's maybe the most striking part.
I agree. In one survey, 52% of Mutti members said they have never experienced a stockout at a Mutti pharmacy.
Never, compared to before, where empty shelves were a daily reality. That's incredible.
It is. And it's good for the local economy, too. These Quality RX pharmacies saw their revenue grow by 30 to 100% in the first year. They became sustainable businesses.
So at the end of the day, this model gives people real financial protection against getting sick. It lets them afford the full course of therapy.
Which leads to much better health outcomes overall.
So what's the key lesson here?
If you look at their whole journey, The lesson is that true systemic change in African healthcare requires doing everything at once. You have to vertically integrate the supply chain with VMI,
Hmm.
introduce innovative financing with consignment stock and patient credit, and control the last mile with the franchise model and fixed pricing. You can't just fix one piece of the puzzle.
You have to align all the incentives from top to bottom. That vertical integration transformed failing local businesses into these profitable anchors of community health. So that leaves a really big question for you to think about.
Mm-hmm.
If an innovative private company like mPharma can achieve this kind of scale and price transparency across 9 countries, what specific regulatory changes should governments in Africa now implement or maybe remove to help accelerate these benefits to the other 70% of the population who are still so underserved?
Huge question.
It is, and that's the question we'll leave you with. Thanks for joining us for the deep dive.